with the Family and Child Health Division at the Vermont Department of Health, and I'm here with my colleagues from the University of Vermont Medical Center and the University of Vermont Lerner College of Medicine, pediatricians Dr. Breena Holmes and Dr. Becca Bell. We'll start our time with a 30-minute Q&A session, followed by a structured content presentation. We received some great pre-submitted questions, but feel free to put questions in the chat during this time. Our structured content section will start at 1:30 and focus on winter car seat safety, a reminder of COVID and exclusion policies for infectious diseases, and immunization requirements for childcare. As we answer the pre-submitted questions, please feel free to ask live questions either by raising your hand or using the chat, and to share any follow-up questions or ideas as we go over the questions. So one of our first questions is what to know about pneumonia, walking pneumonia, and prevention. I believe you're going to give this to Dr. Bell.
Hi, everyone. It's nice to see everyone. Thanks again for all the work that you do. I know it's a busy time of year, and it's a time when kids are getting lots of colds and illnesses, so I know it's tough. For those who don't know, I'm Becca Bell. I'm a pediatric ICU doctor at UVM Children's Hospital. And there's a lot of great questions in here that people submitted, a lot around respiratory illnesses that you're seeing or you anticipate seeing. So you've probably seen the headlines or heard from families that there's a lot of young kids, so sort of like your age, toddler and up, toddler through elementary school kids, I would say, and some adolescents as well, with pneumonia. The type of pneumonia that we're seeing a lot of right now is a pretty common type of pneumonia called caused by mycoplasma, which is an atypical bacteria. It is like I said, very common. We kind of see it all the time. The other way people might talk about it is walking pneumonia, and it's so called that because most people have mild versions of it, meaning you can walk around and like do your stuff and you're not too affected by it. But of course, just like every bacteria and virus that causes respiratory problems, like we do see some kids who get pretty sick from it. So we are seeing a little bit of it in the hospital, a little bit of it in the ICU. It's not overwhelming us by any means. We're seeing a little bit more of it than we do in typical years. And we've talked before in this meeting that after COVID or during COVID, a lot of different respiratory pathogens or infections got sort of suppressed, and then they've come back in different patterns. And so this is sort of what we were seeing. We saw this in different parts of the world last year where there was more mycoplasma pneumonia. So what do you need to know about, what do you need to do about it? And actually, and what do families need to know? And it's really nothing new or special or different or unique. And that is because there's what you would do is anything that you would normally do. So if a child's got fevers and they, or they can't participate in the day, then, they can't be at childcare, they can't be at school. There is testing for this type of pneumonia, but in most places, including here at our hospital, it takes so many days for the test to come back that we don't even really bother with it. So it's not something that you need to say like, oh, there's a lot of mycoplasma going on, you should go get tested, because the testing, we kind of have to decide whether to treat or not, or what to do about it without the test. So the testing isn't really helpful. And then the question is, what do we do about it as clinicians? There is a antibiotic that we often use for this. It's called azithromycin, and it works okay for this, not great. And it's not something where, like for instance, when we saw a lot of group A strep, terrible pneumonias like 2 springs ago, where we were like, please get on antibiotics quickly. This is not that type of thing. It's sort of people get better with and without antibiotics. So that's all to say that it's going around, people are getting sick, and you hear about kids getting sick. And I think I wouldn't treat it any differently. You don't need to run out and get a test. You don't need to like run out and ask for antibiotics. I think if they're sick and they can't participate, they should be seen like they normally would, regardless of whatever is causing it, regardless if it's like RSV or rhinovirus or some virus or this. So yes, it's going around. So you're not crazy if lots of kids are getting this. They do, like other types of respiratory illnesses, they do tend to cough for weeks afterwards. And I think that probably melds into the next question around the stay-at-home protocol, which again, we just highlight, it doesn't really matter what virus or bacteria is causing the infection. It's really about the child, how well the child is, if they're able to participate, and all that same exclusionary stuff around fevers and, vomiting, et cetera. But I'll pass it off to Breena so she can introduce herself and sort of weigh in too on that question of kids, when kids need to be excluded from care.
Thanks, Becca. Breena Holmes here. So I'm a general pediatrician. I've spent a ton of time in public health in the last decade, which is probably why I'm more familiar to you. And when I see your names on this Zoom every couple of months, it creates a very warm but an emotional reaction because of the familiarity of all of you still doing this great work, but also what we went through together. So thanks for always bringing me into this space. Um, I have learned so much from you about this exclusion and when to get back to the business of childcare for young people with illness. And I love that you can come on and bring forth this language because the term walking pneumonia and the headlines about pneumonia, it really does create a feeling that there's something like to be managing as though we're in crisis again, the way we are all of us experienced during the pandemic. So there's the couple things about that. I just continue to want partnerships between you and the people who deliver healthcare in your communities and the families you serve. Because this decision about who's well enough to participate in your program is yours. It's the recognition of how you're staffed and how you conduct your day and what you're observing. You're the one that says, but gosh, Johnny came back and he's not well. So that piece really matters to me, and I continue to offer if you're having communication challenges in your community with child health professionals, Becca and I want to know about that because we want to call our colleagues and say, hey, there's some challenges out there because this is a really hard time with respiratory illness. Now, that being said, you're not in a reportable disease space here, and you're not at any risk that if a kid is done with fever and comes back and still runny, that it's a higher, spread than all the other viruses that you're so used to containing. And so your hand washing and your hygiene, which you're also good at, it's just that you just double down on all that. And but we've all done all that and still had a kid sneeze in our face or wipe his nose and then give us a big smooch. So figuring out how to keep your infectious disease protocols as tight as possible is the goal here, not to change anything based on headlines or feeling like mycoplasma's floating around. I am fascinated by mycoplasma for the reason as a treatment provider, when I used to do prescriptions, because it does not respond, that bacteria, to the penicillin amoxicillin products, which is why it gets a little uh, undertreated sometimes or is hard to treat for the reasons Becca just described. It requires a different antibiotic class, and even with that, isn't really that effective because of the way it affects the respiratory tract. And you do tend to have some inflammation that persists even after the virus is gone that leads to this persistent cough. And yet you're still walking around, which is why it has that term, as Becca said. I think that puts a end to that conversation, but I know it's not simple and that you have ongoing challenges with this. Always have, right? Even before the pandemic.
Next question, I was hoping Amy, our licensor on duty, could answer. It is, what are napping guidelines for 3 to 5-year-olds?
Hello, everyone. So for licensing, and this is whether you are in a in a center-based program or you are in your own home, you have your program in your own home. For 3 to 5-year-olds, there is a specific section that talks about safe sleep practices, and it starts with infants and then goes all the way up. And there is a regulation that states that children need to be offered the opportunity to rest, whether those kiddos are falling asleep or not. They need to be, if a program is open for 5 hours or more, they need to be offered that opportunity to rest their bodies and kind of recharge. However, subsequently, the rule following that states that they shall not be required to sleep. Children, every kiddo is different. So if you have a kiddo or kiddos that don't fall asleep after that offered time of rest, quiet, then providing quiet activities, whether it's books right there on their mat or we see programs that have quiet bins, things like that. So offering them something that they can do either there on their mat or at a quiet section, if you have the space to do so. So that's kind of what we see for those, or what the regulations state for children over the age of 12 months. Does that
Thanks,
answer
Amy.
questions? You're welcome. You're welcome.
Was to say that this is another of the opportunities for you all to partner with families,
Yes.
because everyone carries that observation that you get a kid home that's napped and now it's 8 o'clock and they're having trouble shutting down. And it's not actually always accurate, but it does create a feeling that parents wish something different was happening in your care, and the ability to kind of talk that through as a team would get out ahead of that. Why'd you let him stay asleep for 2 hours? Which I'm sure you've been a part of those combos. So I like this Cleveland Clinic. By the way, my adult children tell me I botched a lot of things in their care in raising them, but I did great with sleep. I was completely obsessed with them getting enough sleep. And so it's nice barometer for you all to know that a toddler needs about 10 to 13 hours. That's a pretty big range. And obviously there's a lot of individuation there, but that if you're hearing from families they're getting 8 hours a night, then you're going to be in a nap zone. And that might be a young person that really does need to shut down. And then this idea of quiet time, which I know you're great at, is a nice alternative. So you don't have to stay full on for the entire time a child's in your care, a little rest without actual sleep. But I bet parents have a lot to say about this one. Thanks for asking.
You're welcome. Can I add to that a little bit? So just to piggyback that, we do often get questions from providers or have providers reach out that say, Sally's mom came to me and said, she does not want me to let her nap. She doesn't want me to let her rest. She doesn't want me to even put her on a mat. Or Joey's mom wants me to wake him up after, he falls asleep as soon as his head hits the mat. She wants me to wake him up after half an hour, 40 minutes. It obviously puts folks in a tricky position because not only are there the regulations regarding, being offered the opportunity to rest, but there's regulations in there that talk about making sure that, nurturing activities, whether it's resting, feeding, things like that, are done at a developmentally age appropriate, with that lens. So we tell providers, feel free to push back using regulations, but put it on the regs. Say, I can't, this is what the regulations are telling me. There have been times where we have had situations pop up where we've advised providers, say, talk to your pediatrician, and if your pediatrician can get you something saying that, it's appropriate for Joey to be only sleep for half an hour because he doesn't need it, then as long as the program has that documentation, you can wake him up. But it definitely creates a tricky spot for providers. So we definitely recognize that. So I just want to put that out there.
Thank you. I think that was a very important piece to add. We have a question for Breena. Any advice for those of us lacking specialists, dental, vision, ENT care.
Yeah, I have a lot to say in that space as well. I did want to add one more thing to Amy because this one's so near and dear to me. I think one additional question for families in the space of please don't nap, please wake them up would be tell me more about that. What are you experiencing and why? Um, this touch points work that we do, which is when things come at us like that, like a shift in the day or a request from a parent, sometimes we move quickly into like, ah. But if we could stop and wonder with them, we would learn something. And could you imagine a world where a parent says, when I get my child home and he's not tired for bedtime, my husband is starting third shift at the hospital and he's trying to rest and the chaos in my house is creating a lot of stress. And then you know something more about why it's creating the pressure point instead of just do this. So the specialist, so I need to know more about this question, of course, because we believe so deeply in Vermont about this thing called the medical home, which is, and I always love to call out my Head Start colleagues because the idea that that there's a place that's, a true medical hub for the children in your care where they get their comprehensive and culturally appropriate and consistent services matters. And so when you're in the position of holding that a child's not having a dental screen or a dental visit or a vision screen or even getting subspecialty care at an ear, nose, and throat specialist, I can feel that pressure. And I'm wondering if you want to hold that observation and frustration with their medical home, where the solutions might be shared. And this is interesting because, our colleagues at Building Bright Futures have asked, maybe some of you are not involved with this, but there's a subcommittee called Child Outcome Accountability Team that has asked in December for a bunch of us to come on and talk about when to screen for vision, how to get kids referred. And it feels like our early childhood system is holding this observation that kids aren't getting vision screened. And so I need to double down if your kids you're serving are not being screened or for vision or seen by dentist or even having a place to go when they need ear, nose, and throat. That's a great bring it to Breena and Becca. So we would need details. We need region, we need age, we need access, because what we'd really like you to do is find a medical home for that person and then wonder why, because then the medical home they have long lists of dental access in medical homes. That being said, the health department used to, and Julia can be my fact checker here, we have an incredible oral health program where they have a resource on their website of dentists in the region, each of your regions that receive children and also Medicaid, which is very important. And I can find that while someone else is speaking. And then ear, nose, and throat. Interesting long conversation from my community pediatric practice about based on the age of the children you're serving, I would imagine you are seeking a pediatric ear, nose, and throat, which would be UVM. We don't have those at community hospitals. Now, I don't want to get in trouble, and sometimes a community ear, nose, and throat person who sees adults and kids is comfortable with things in that space. But again, that would be a decision you'd want a family to be making with their pediatrician. Anything about that, Becca? That feels like you might have some observations too.
No, I think that's right. I mean, I think coordinating with the medical home is like they're sort of dealing with this a lot. So the question is whether these kids don't have medical homes or maybe they haven't checked in to know that that's probably the best point. Yeah, for pediatric ENT, it's UVM, or if you're closer to Dartmouth, Dartmouth also has ENT. So, but your medical home, the child's medical home would know that.
Can I just contribute to this conversation? This is my question. And these are kids that I have screened. So generally they are 3 to 5 year olds, but not all, some are younger. And they're required to be screened by Head Start. So when we know that they've failed the screening, they need follow-up care. They don't need just screening, and they do have medical homes. In general, the medical homes don't have screening tools to appropriately screen the children. The EI program in Bennington is now doing it for kids that CEI. So the EI kids get screened, the Head Start kids get screened. If we have the Lions Club will screen them for vision also. So some of the kids in Bennington County get screened, but by all means, not all. And then they have to be referred. Who would you like us to refer them to? Because we don't have local ENT providers. We have to go to Rutland. That's the nearest. We have one dentist who will accept Medicaid for children, and has dramatically cut back on who he will see, dramatically. Dr. Brady, who's, as far as I'm concerned, a god, but he's an aging god who is retiring very, very, very soon. And we don't have anybody closer right now than, I believe, the Rutland Montshire Pediatric Dentistry just opened. The Brattleboro office has not yet, but those are both an hour and 10 minutes away from us. We have nobody who will provide pediatric glasses for Medicaid patients. We have one provider who will provide Medicaid vision exams, and that person decided over the summer that they didn't want to do it anymore. Like, where would you like us to go? Just asking.
Yeah, no, thank you, Grace. I do think you're part of the planning for this BBF summit on December 5th too. I saw your name where we've invited the pediatric ophthalmologist, sort of outreach coordinator to come and wonder about this with us. I don't know, except it's very familiar that different regions have hit these deserts over time. And it's very surprising to me that Bennington's one of them based on the Molly Stark Clinic and everything that dentist has done for your community. But the legacy of that is we still talk about. So the fact that it's as acute as you're describing is pretty jarring to me, as a person on that Route 7 corridor. So that's going to require advocacy from all the partners to continue, including the health. I would hold that at the health department, the district office, to bring that to policymakers that it's not ethical. Because the whole part of screening is if you don't have anything to do about the screen, you really shouldn't screen, right? That's the ethical principle of screening. So you're hitting something very powerful that
There is stuff we can do about it. It's just that everybody who gets screened and fails must travel. They must travel
right.
at least an hour, which is sort of an unfair burden to place on people who are.
No, that's right. Very important to say it in every meeting and find the right people to create solutions because there needs capacity building. I'd love to talk offline too, because we could use some of the pediatric voice to amplify that as well. Thanks, Grace.
And I would highly encourage anyone having any local health problems to reach out to their local health office. We have family child health nurse coordinators in every region who work very closely with providers and have a great wealth of knowledge and understanding of what resources are in your areas. If anyone is unfamiliar with their specific family child health nurse coordinator, I can give you their contact information as well and help to facilitate that connection. We do have another question that the whole team or Amy can answer. It asks a review of recommended illness policies for licensed care and potentially any other resources that we have.
So just clarifying, is this a question about what to follow for guidelines in terms of the child development division? Am I understanding that correctly?
I believe so.
Okay. So in the back of all three program regulation books. So whether it's an after-school program, home program, or center-based program, is the signs and symptoms chart, which we follow the CDD recommendation. CDC. Sorry, got my letters all entangled. The CDC guidelines as far as that goes. And that is not to say, however, that as a program, providers cannot go above and beyond if they are feeling as though it's in the best interest of the child, in the best interest of the program. As someone mentioned earlier, there's not only, okay, do they have a fever? Yes or no, but also, are they able to participate? Are they able to, um, you know, be part of activities, get through a normal day, or is whatever is going on affecting their ability to do so? An example I use quite frequently is, CDC says that a child can return to care after 24 hours of being fever-free without medication. However, we've seen an uptick, especially since COVID. Some programs are saying, nope, we want the child to be 48 hours fever-free. And again, as long as whatever the program is opting to do does not contradict or go against what's in that signs and symptoms chart, as a business, you can certainly do that. Does that answer the question, hopefully?
Yes, I think that was great. It's very important that we reiterate that you can set these guidelines and that you should be following what you think is best as the provider for both you and your staff and also the children.
Yeah. And there actually is a regulation, again, for all three program settings, that a copy of the signs and symptoms chart is available and clearly visible to staff and parents. So that needs to be readily available to everyone. So ensuring that that's posted as well.
I believe we
Yeah,
have
just add, Julia, let me just add one more thing. I thought Becca might say it too. So this is an interesting space, and I really support the autonomy piece and this notion that you have your own uh, autonomy, but I would really wonder about a circumstance or a time where you wanted to sort of change the infectious disease guidance here. Do you know what I'm saying? Like the absence of fever or I don't know, Becca, I wasn't sure if we were going to address, I guess COVID's coming up in the second half. We're finding ourselves needing to try to get back to some semblance of normal here, and our very reasonable heightened fear of virus from that dark time may be influencing the way we think about return from illness. Do you know what I'm saying? Just trying to have an honest space here that we don't want to go too far off of what's true about contagion
Right,
and
absolutely.
return.
And
Yeah,
yeah, I mean, it's kind of there is the option to go, regulation state, you can go above and beyond, but at the same time, keeping that realistic, kind of perspective on it, and, having that thought process of, is this really beneficial? Is it necessary? That whole sort of thing. But I just really wanted to stress too that that if you're going to veer from the chart, that it's not anything less than what the chart requires. That's the key piece that I think program providers want to keep in mind, is that,
okay,
like, for example, the fever thing. CDC says it has to be 24 hours. A program couldn't come along and say, it's okay, it's been 12 hours, Johnny
got
can
it.
come back. That sort
Right.
of thing.
No, that direction
So,
makes sense.
yeah,
I think that
yeah,
we've had experiences with the ongoing confusion about COVID that people have made their own, and we'll hear about this in the second half, but there is no
yeah,
longer a set of protocols about what to do with people with COVID. I mean, it's very much regular infectious disease advice. So that was the space I was concerned about, was
Yeah.
going
Yep.
beyond it, like saying you can't come back for 5 days, even though
Right.
you're well. Yeah.
Yeah, absolutely. Yep.
Would just like to reiterate that all of us on this team and myself are accessible to everyone, regardless of it's during a webinar or not, and that you can email us with any specific health and safety questions, and we will get back to you as soon as possible. And if we're not the best people to understand the guidelines or something around a specific disease or health and safety concern, that we will connect you with the experts holding that information. And I believe we're at our last pre-submitted question. It is working with health providers regarding early Head Start rules and licensing. And this does come from an early Head Start partner.
Did we think I was answering that one?
I believe we
Try to,
did.
yeah. I think this question, and I'm so glad that Grace unmuted and described that I was answering the question wrong, because it was, or that it was different than what it was described. So is this about the same idea, that how do we assure that there's a good, strong partnership between medical homes and Head Start? Is that the intent?
I think this came from an early Head Start partner as opposed to Head Start. And so that's someone who is trying to get Head Start requirements met, working with a medical home or a family that some other children in the program might not have to meet. But if the person who asked that question wants to chime in, please do. I know you're on the call.
I'm here. Hi, it's Beth Traver Adolphus at Oak Hill Children's Center. And I sent the question because we, we find ourselves walking that line. We want to make sure everyone is safe and healthy in our center, and that illness does not spread. We also recognize that families whose children are ill and they have to keep them home, are sometimes in danger of losing their jobs, etc. We have, from the time of the pandemic, we have a COVID mitigation strategy that was required as, part of our Early Head Start partnership. And it basically says, you need to exclude anyone who's ill. So, one of the things that sometimes happens is, if we send a child home, they'll take their child to the doctor will say, oh, you don't have to worry about it, and
Right.
and the child will come in and be hideously sick. And so I'm not really sure, how to, because they, the doctors also understand that families are under stress and that they're worried about
That's
losing
right.
their jobs and
Yep.
things like that. And so I'm just wondering how to move through that space together, to be fulfilling our obligations as a partner, and to our other families who are saying, why do you have this sick child in care? My child's going to get sick. I'm going to miss work, right? Because
Yeah.
you have both ends of the spectrum, right? You have the ones who are going to need, they feel like they need to send their child sick or not. And the other, end of the spectrum, where you have families who are saying, I don't want to see a sick child in this class.
Totally. Yeah.
So I'm just
This is this falls in squarely into I'm with you, Beth. This falls squarely into relationships. No protocol in the world can fix this, because protocols are meant to be sort of guardrails. And what you're talking about is an understanding of each other's worlds, both yours and all of your providers, the medical setting and the families. And so the pressure point here that Becca and I have been trying, we have these roles in the American Academy of Pediatrics, and we're trying to tell our colleagues, slow down for a second and find out what's going on in the day of the child when they're in the care of the child care, before blanketly saying everybody's fine. And so that space we're trying to hold for you, and we'll do it for as long as needed. We're just bringing people into your world, which is, it's not the same as if Johnny can watch TV on his grandmother's couch. It's a program where he's trying to function and he's not well. That's been a big disconnect, and we know that's ongoing. But the other piece is for you to get to team up with your local medical professionals to understand what they're experiencing so that you can feel like you're in a collaborative space in the care of these families. Because what happens on the medical side is the frustration grows. The parents come and say, can you just write a note that says this kid's fine? And the doc is 45 minutes late and was up all night on call and is like, here's your note. So it's that lovely thing we all do, which is just spend 5 minutes in my shoes, parent shoes, childcare awesomeness, and these really, it's very difficult to deliver healthcare right now, and it's very difficult to be in childcare. So you guys could really share that space. And so you're going to think we're overpromising this, but Julia's right. We do have these incredible family and child health coordinators in every district office for public health who know the medical professionals in your town. That's like their primary job, is to know who's delivering healthcare for kids. And so they would be a cool outreach to say, hey, because it's not all your docs, I know for sure, it's some of them. And so if you call your family and child health coordinator and say, I'm really not doing relationally with Breena Holmes. She's just off the mark with these notes. There could be a nice little quick meeting. And I'm not adding more meetings to your day, but if you could just have a little bit of a shared space, it would go so far, because after that you could then grow your vision screening advocacy, and you could wonder where you're going to find dentists who take Medicaid, right? Like there's a whole once the relationship is established, the sky's the limit. And I'd love to help you. That it's a really small state. And Becca and I know every single pediatrician. That's not hyperbole. So if you want to slip us a little email that says this is the doc that's writing all the notes, we could work our relationship strategies as well, which may or may not be successful because people are people.
Well, and I think, I can also understand that the doctors are probably getting frustrated with families coming to them because their child has, symptoms. And if it's not some kind of major, horrible contagious thing, they may be feeling like, okay, this is such a waste of my time. I have so many people I need to see. And I totally get that.
But that's so beautiful, Beth, and we can end there because Julia's gonna be mad at me. We went past our time, but that coming alongside people is where we need to be in this world right now. We just have to understand that we're all doing the best we can, sort of, but we're breaking down on the team, and that takes time. The forming of the team and then the maintaining the relationships with the team is low on the to-do list of the day, and I think we'll do better when we put it further up the list.
I'll also just add that I think most of these cases exist in this middle space, right, where the child is not well enough to attend a full day of childcare, but they're not sick enough to even need to see the pediatrician, right? Like there's so many, if you think about it, there's so many instances where kids or adults are too sick to like have a full day of work, a full day of school, a full day of childcare, but they don't need to go see a physician about it. They just need a day or two or whatever. And so I think people are asking different questions, right? And so your question is and it's you and the family, is this child isn't able to participate in 8 hours of the day, right? They're like too sick for that. But then if they go to the pediatrician's office and the question is, can they go to school, or can they go to childcare, can they go to school? Then the pediatrician will be like, sure, if they're well enough, right? And so I think, or it's like, do they need antibiotics? And it's like, no, you don't need any treatment. So I think most of these cases are existing in this middle space. And so what we really try to discourage is a requirement, and this is hard because there were parts of early COVID, where we were requiring families to go get a test before they came back, or to go see a healthcare provider to come back. And we're really discouraging that, right? They should see the pediatrician if they're sick and need to see a pediatrician, but not whether they can be in school. Is the pediatrician's not they're going to see them, for 15 minutes, 20 minutes. It's not about like, can this person participate for 8 hours? That is a conversation really between the family and the childcare. And if you're saying, look, I know like an hour ago when you dropped him off, he was doing okay, but then it's been 2 more hours and he's been laying around and he won't drink anything, that's like the pediatrician can't really weigh in on that piece of things. So I think just making sure we know what the question is and what people are assessing and evaluating for. And then the other piece I would just add is we did learn a lot during COVID, and it's true of a lot of different infections. When we're thinking about contagion, and it's tough because I've presented to this group before, like when you swab little young kids' noses, so exactly the kids that you care for, like every week, there's like all through the winter, they have some sort of virus, right? And they're sick for some of it and they're not sick for some of it. And we remember during COVID that there was a lot of pre-symptomatic spread, right? And so what I think a lot of thinking about school and childcare exclusion is thinking, it's not going to be perfect. We're going to have kids and adults who could spread something, but like when is the time when they're sort of most contagious? And that luckily lines up usually with when they've got fevers, when they're feeling the most sick. It's actually usually when they're most contagious, and even a little bit before they get sick, which is hard. So that when you're thinking about like the other families and kids getting sick, I think what can be a big focus, which is not quite right, is the kid who's sick, they have like a fever for a day or two, they stay home appropriately, they come back and then they cough for 2 weeks. And everyone's like, oh my gosh, this kid's coughing, he's contagious. And he was most contagious really around the time he had a fever. And so the exclusion policy sort of is supposed to match around when the kid's sick and they can't really participate, but also when they are most contagious. So that post-viral cough, that can last like a long time. It's not super contagious. So I think that's sort of the tricky part too, but it's a thing that you hear and other families hear too, right? They show up to pick up their kid and like they hear all this coughing happening. And so I think like that time of fever, that time of feeling the sickest is the time they stay home. It also happens to be the time they're most contagious, which is sort of helpful.
I do want to make sure that we have time for our Megan Carey from our immunization program to present on the immunization requirements for childcare. Megan, if you could share your slides, that would be great.
Perfect. Thank you so much. One moment. Are you able to see my screen? I'm sharing it in an Adobe format because that was the easiest for me. Hopefully you're all able to see it. Perfect. Lovely. Hi, everyone. My name is Megan Carey, and I am the Child and Adolescent Nurse Coordinator with the Vermont Department of Health. Jess Buchanan, her name is on the slide. She's the Immunization Team Communication and Training Specialist. Her and I work together to oversee childcare, school, and college immunization requirements. Unfortunately, Jess isn't able to join us today, so I'll be leading the presentation. Go light on me, please. I'm just kidding. And the purpose of this presentation is to provide a broad overview of the Vermont childcare vaccine requirements. This is just a brief agenda of the topics we're going to be covering over the next couple of minutes. I do hope to leave a little bit of time for your questions at the end, but I know that overall we're a little bit tight on time today. So any questions that we might not get to, I'll also provide our contact information and we'd be happy to follow up outside of the meeting. So just a quick overview of what the VDH immunization team's responsibilities are and aren't in regards to the immunization requirements. So the immunization team is happy to answer your clinical questions about catch-up schedules and related topics. We collect and analyze all incoming school immunization data, which we then share on our website and report to the CDC. Additionally, we can provide presentations just like this one and offer valuable resources and knowledge. Each year, we update all necessary forms and can create translations of those forms upon request. You are all often the folks that, get questions from others in the community, and you do a really great job of passing along any questions you're unable to answer. As for what our teams are not responsible for, we're unable to translate immunization records that are not English, and we don't enforce the six-month provisional admittance guidelines. And we'll talk a little bit more in a moment about the provisional admittance guidance. Displayed on this slide are the required vaccines for childcare entry. The table The table to the left shows the required vaccines by age of enrollment. The Vermont Recommended Immunization Schedule follows guidelines from the Center for Disease Control and the Advisory Committee on Immunization Practices. We also call that the ACIP. Vaccines required for childcare or school must be given at the right ages and intervals with a 4-day grace period allowed for some doses. When enrolling their child, parents must provide an up-to-date immunization record from their healthcare provider or the state immunization registry, or they must provide a signed exemption form. With the parent's permission, childcare providers can access the immunization registry to check vaccine records and ensure compliance. And towards the end of our slide deck, we do have a link on how anybody who is interested in getting IMR access can request that. Parents who don't provide a full vaccine record or a signed exemption form can submit a provisional admittance form to the child care program. The provisional admittance section of the Notice of Missing Immunizations form, which is a form that we also linked in this slide towards the end, must be signed by a healthcare provider and submitted by the parent to the child care provider upon entry. The child must be catching up on missing vaccines in accordance with CDC's catch-up immunization schedule, and provisional admittance can't last longer than 6 months. So again, children can be provisionally admitted into childcare programs, but there has to be a plan to get them caught up on vaccines and following that CDC catch-up immunization schedule. Children with medical conditions preventing vaccination can have a medical exemption, but the form must be signed by a licensed healthcare provider. Non-medical exemptions are allowed for children whose parents or guardians have religious objections to the vaccines. And to claim a religious exemption or non-medical exemption, parents must review educational materials and submit a religious exemption form each year. So that's an annual form that has to be submitted, and it is led by the parent. They're the responsible party, parent or guardian, for making sure that paperwork is in on time. Now, just the last note on this slide here is keep in mind that any exemptions claimed may result in exclusion from the child care if there is a disease outbreak, if it's determined that the child is at risk for getting that disease and transmitting it to others. And the length of time for that exclusion is very much dependent on the disease. That can sometimes range from a couple of days to more than a month. All regulated childcare programs, except for after-school only programs, are required to complete an annual immunization survey. If a child attends more than one program, let's say like preschool, Head Start, or home childcare, each program has to have a copy of the child's immunization record and include the child in the survey. Licensed or registered childcare programs are responsible for keeping these records, but once a child reaches kindergarten through 12th grade, the school takes over reporting the child's immunization status. Additionally, center-based childcare and preschool programs must publicly share their vaccination coverage data for each required vaccine, and this information will be available on the health department's website and updated every year. Childcare providers must review immunization records and exemption forms annually. They should look for an email from the Child Development Division in the fall with a link to an online survey that must be completed by January 1st. The survey does not include children's names or vaccination dates. The Health Department and Department for Children and Families then reviews, summarizes, and publishes this data. And before I open up for questions, I'm going to actually go through. I've got a couple of resource slides here that I just wanted to quickly display with some helpful links. All of the childcare and school paperwork for exemption, medical exemption, non-medical exemption, etc. The vaccination requirements and reporting facts, that is all found, the links are all found on this slide, but it's also all on the VDH webpage. And Jess and my contact information are listed on this slide here. I will share the PDF that I'm showing you right now. That way it can be accessed after the meeting. But the I think it's the fourth bullet down here, request for IMR access. If there's a child care provider that wants IMR access, they can submit that through that link. The last thing here is translation resources. We do not translate we don't translate immunization records. And I don't feel like it'd be super likely that a child care facility would need this, but we wanted to make sure that we included translation resources for translating those records. That way they can be more easily read to determine if the child is up to date. And now I have questions, if open for questions if we have time. Otherwise, I'd be happy to answer them via email outside of the meeting.
We can take questions. I think that we can push our winter car seat safety to our January meeting. We will definitely make time for that. So if anyone has questions for Megan, please use this time to ask. Yes, and we will get the slideshow to you all as a PDF so you can print it out.
I have a question. About the translated records, Megan. I understand sometimes when we have kids that come from, I'm thinking specifically Central American, South American countries, that sometimes those vaccinations are not accepted as being valid. I understand that they can translate, like, sorry, most of the time I can figure out which vaccines they are, but I can't figure out whether or not they're going to be validated in the US. Will these services also validate the vaccinations?
Yeah, the translation resources provided in the slide deck are resources that are mainly around the names of the vaccines in other countries and what they might correlate in the US. If there's questions around after that's been translated, let's say polio, for instance, if there's questions around if that specific polio vaccine is acceptable in the US, feel free to reach out to Jess and I. I'm the clinical side of our program. And so I'd be happy to do some digging. Whenever I have questions that I can't answer after doing a lot of research, I typically will reach out to the CDC directly and have them provide the guidance. So yeah, for those specific scenarios where we're not quite sure, after interpreting the immunization history and the vaccination records that, we're not sure if something is accepted in the US, we'll be happy to help, with that part of it.
Okay, and my other question, thank you, is in terms of provisional admittance, when we have a child that enters our child care and we know that they are going to be getting caught up, or at some point in time, if they've done a waiver and they've decided that they're going to start getting caught up, and we are switching over to doing provisional admittance, I did not realize that we had to have that completed by a doctor. How I guess my question is, this is something that I would have thought of when we submitted information to the state in December. Should we be doing that at the beginning of the year now, or and just like when does the clock start on those 6 months?
So typically it starts when the provisional admittance is made. So at least that's my understanding, and I will confirm with Jess because she's more of the content expert as far as the times. I just kind of want to go back to the first statement. It doesn't have to necessarily be a doctor. For instance, if there is a nurse that is reviewing the records, it just has to be a healthcare professional. The last thing we'd want is for, somebody that's not in the healthcare field to be filling out these forms, and then for, the form to not be actually correct. Not implying that anyone's going to forge those, but, I don't know. It's always possible, right? So just making sure that there's a healthcare professional that is signing them and they have the plan. But it is my understanding that it's 6 months from the time of the provisional admittance form. So they bring their immunization records, their provisionally admittance. That's kind of when the clock starts. But I will confirm with Jess just to make sure that that's
good to know. It's 6 months. All right, thank you.
Of course.
Megan, there's a few questions in the chat. Desiree wants to know if the immunization survey has already been sent out.
Good question. That I don't know. Jess leads that. So let me write that down so I don't forget these two questions. And I apologize.
We have
it's
not
virus season.
we have not received it, Breena.
Okay, Grace is saying no. So that's good feedback for the field that's coming. And then Tammy has a great question. Currently only have access to the immunization registered up to age 5. It would make our job easier if we had access to records for all children in our care. Can you take that one back to the
Yeah,
folks
I'll take
too?
that to the IMR team, absolutely.
I think what Tammy's saying is she probably has after school kids that come in and they're over 5, so that's
Yep.
helpful. At the top of the hour here, I do want to preview something. Becca and I are heading into a project with the health department, wondering what our great network of providers, both healthcare and childcare and others, need to have conversations with parents who are hesitant to vaccinate their children. So I have not even told Beth this yet, but we may want to use you all or a subset of you in a conversation about what's going on out there in your conversations with families and kind of the myth busting piece, but also sort of what are the skills that you would like to have when you're as a very trusted member of a family's life asked a question like, is this safe or is this, what should we do? I'd love to spend more time with you and figure that out because we're always at risk for major outbreaks in this great state because of these pockets of less immunized communities.
I would absolutely love to. It's my passion. And this is something that we actually teach to providers through an immunization quality improvement program that we call IQIP. Not every provider practice is enrolled in IQIP or engaged, but the two things that come to mind is the healthcare professional is the most trusted person, to provide the vaccine recommendations. So the knowledge really starts there, making sure that the healthcare professionals feel comfortable with the vaccines, understand that they're safe, have the information to relay to the families. And the second piece of that is also providing a strong vaccine recommendation using presumptive language. So that might sound something like instead of saying, little Timmy can get a couple of vaccines today. Have you thought about what you'd like them to get? It's very strong. It's, little Timmy is due for DTaP and polio and whatever vaccine today. I feel strongly about these vaccines. They're going to, boost little Timmy's immune system and provide him with protection. So there's some really great resources out there to help providers and really develop that relationship too. I think that's the other piece. We learned from COVID to not push vaccines. We really don't want anyone to feel forced. We want to keep that door open, though. Keep those opportunities coming for conversations because that's really where we break down the myths and the misconceptions, and that's where we build the trust. So feel free to include me. I'd love to do that.
Being that
Thanks, Megan.
we are over time, please feel to reach out to Breena, Becca, myself, Megan. Thank you. A big thank you to everyone who came today, and thank you to Breena, Becca, Amy, and Megan for your expertise, and Beth for your support and technical assistance. We will see you all in the new year, January 9th from 1 to 2 p.m. In the meantime, please feel free to reach out to us as a contact for any health and safety needs or to ask questions or suggest topics for our next webinar. We will be picking up that piece on winter car seat safety, and we will make some more clear language around our current COVID guidelines. Short story, there are none, but please reach out in the meantime with any questions. Thank you, everyone.
Have a great day.